I'm really happy you are physically here, but I also maybe would like to compliment all the online visitors, because we have someone here all the way from Aarhus, and we only have positive, hey Eugene, we only have positive associations with Aarhus, because Adam Finneman comes from Aarhus, and Adam Finneman did some great work in our team as PhD students on urban mental health. Cool. So I will talk about that later on. But now I would like to introduce Kim Mathiasen. Do I say it right? Yeah. Kim Mathiasen. He's a licensed clinical psychologist, works as an associate professor at Aarhus University. Actually, I've never been at Aarhus University. This is not inviting myself.
Well, you are invited.
But you're also still positioned at the University of Southern Denmark. Also, Kim is a board member of the ESRI, and the ESRI is a European association that only works on one thing, research on all kinds of things that are digital and digital intervention. So if you don't know ESRI, you're interested in e-health and so on, have a look at that.
And ESRI, the same but international.
Yeah. And ESRI, don't make it difficult for us. But most of all, he's absolutely a pioneer in using technology to deliver interventions. And when we talk about technology, we talk about e-health and so on. And he developed interventions, e-health interventions for Denmark. That's the cool thing about e-health intervention. You can develop it not only for your little village where you live in, but actually completely for the whole nation or for Europe. And I'm also looking at two other people who are sitting here working and chairing a European project called Reconnected that urban mental health also has a part in, because you also were responsible for designing and co-designing all kinds of interventions in all kinds of European projects before, and now you're joining this again. So, without further ado, I would like to give you the floor, because I'm pretty sure you're going to talk about how we can actually use technology to deliver interventions.
Yeah,
am I right?
Something like that, hopefully, yeah. Thank you so much, Claudia. That is really the most warm and generous presentation I've ever had.
Oh.
So, but thank you so much for inviting me, Claudia, and Annette, of course, as well, and Michaela, to come here and see your place. I really think this is a fantastic place with the history and, you know, all designed for your brains to meet, right? That's the whole concept, I think, for, if I understand it correctly, of this house. So that's just fantastic. But so today I'll talk. I've started more and more, I think, to call it digital psychology. And if I talk to medical doctors, I call it digital psychiatry. but for today, I'm calling it digital psychology. But the idea is more or less the same. It's using tech, you know, nips and knobs and things and digital tools within interventions, therapy, but also monitoring of patient conditions. And so what I would like to do today is, this is a very broad field, obviously, because it's all of, you know, psychology and monitoring of patients. But so I'll choose some of it to talk about today, and particularly some of it what I have personal experience with, or I've been so fortunate to be involved with. And I'll start a little bit back, and then I'll come to a place where hopefully we can point this field, or my ideas of where this field is now moving towards. I think implementation is an important thing. I might not get too much time to talk about implementation today, but I'll try to squeeze it in. And if some of you are more interested in that, you're also welcome to contact me if you're interested in anything of this. Of course, you're always welcome to contact me. I'm always happy to talk about this. So I want to go over first, what do I mean by this? I've almost already said it. But I think number two is really important. So why in the world would we want to push a machine in between two persons who are trying to make an effort or a change? Maybe we can miniaturize this. minimize? No.
Yeah,
Okay, so this is a bit in the, oh, maybe we can just do that. That worked. So, and then I'll give examples of tools for assessment and intervention and some for monitoring of patients' conditions. I'll talk a little bit about implementation if I have time and new directions. And of course, I particularly also want to mention the Reconnected project, which Annette is PI on, which is a new European project which you guys are also involved in by Claudia and others from this place. So let's see how much we can make today. So first of all, what is digital psychology? So broadly speaking, it's the application of digital technologies in prevention, treatment, and monitoring of mental health. So as you can tell, it's pretty broad. Even with this broad definition, some years back when I started being interested in this field, it was still very narrow what we would actually talk about, but now it's exploding, and particularly in the past decade or so, a lot is happening in this field. So it's really growing quickly. So I don't want to confuse the broad topic of it with the actual technologies being used. That's a common mistake, I think. So, but I'll mention that there are some typical technologies in use. You can use like online self-help materials. You could use video consultation, mobile phones, wearables. AI, of course, is at the top of the hype cycle right now. Virtual reality used to be, but there are many other technologies. But the point is that this is not about technology per se, as it might sound like. It's about ways of reaching people, monitoring people. It's a way of making them more agent or increasing agency in their own illness and so forth. So as times change, so does the tools we use for those processes. Yeah. So these are just examples of the tools that we use right now, but it could, coming back in 10 years, it might look completely different. So this is the key question, of course. It's just because we love computers. Well, some of us do, but it's not the reason, right? It's because of this, and this is also a test of your vision. So for this is probably something a lot of yeah, me too. A lot of you have seen before. It's an examination of background population in the USA for prevalence of mental disorders, and as you know, they're pretty high. It's about 20-25% of the background population if you take all of it together. But it's also there's something that's happening. Peter's been sharing with Teams, so it's a little slow. But it's also this that this is a WHO list over burden of disease for different diseases, and you can see in high-income countries, as the Netherlands, for example, unipolar depressive disorder is by far #1. So, and this is only getting worse, by the way, and it's more and more countries where this mental disorders, particularly depressive disorders, move up to the #1 burden of disease in the country. But fortunately,
yeah,
this is the good news. Okay, so all these dots on the right side of the vertical line here are examples of interventions that work for some sort of mental disorder. Yeah, so we're actually pretty good at treating it. Some of the blue ones are medications, and the yellow ones are psychotherapies, I think it is, or it's the other way around. I think it's like that. But as you can see, they're pretty much very effective, right? So we have a common disorders, high burden of disease, and we can treat them. This should be the end of the story, right? This should be where we end saying, okay, okay, now we can all go home. Problem is, of course, that's not the case. The case is that if we look at how many people then actually receive these treatments, it's only few. So in Western Europe, it's only about half of the population that will actually receive. So this is Alonso and his co-workers made this a few years back. He finds that only nearly half of those who have treatment demanding anxiety or depression have had any contact with the healthcare system within the past 12 months of when they asked them, right? So this is terrible. So compared to, for example, they contrast it to diabetes where it's only 8%. So that's where we need to go, right? We need to enter the 8%, not at the 48%. So we can treat them, but people don't actually receive the treatments. So this, of course, is the original reason why we start thinking about, can we deliver these treatments in a different way so it gets in the pocket of everyone who needs it? So we can increase reach. We can also, with new monitoring devices, reach more data-driven personalized treatments. I'll come back to that later. Hopefully there's a promise of increasing prognostic abilities. Right now it's almost impossible for a depressed patient coming into a psychologist or a psychiatrist, then the treating clinicians cannot tell them how long will it be before your disorder is gone, or will it even be gone for you in particular. What are your odds? We almost can't do that, not on a personal level. There are some disorders we can treat with use of technical devices that you normally can't. For example, fear of uncommon phenomena like thunder or flying in planes or something like that. We can also, for example, in Denmark, it's probably the same here. This is the case in many countries, that it's way easier to receive high-quality treatment in the cities than it is in the more remote areas, in rural areas. This is certainly the case in Denmark, and Denmark is a small country with high level of urbanization. But if you go to Sweden, it gets worse. If you go to the US, it's much worse. Go to Australia, much worse. It's very difficult to distribute treatments in some of the areas of the country. So there's a level of standardization of treatment that anyone can get access to evidence-based treatments, for example. That's extremely important. So it's not where you live or how much money you have, but you should have some sort of access. All right, so let's go into describing some of the tools that are available for this. This is what I've been working with most. I would venture saying that this is by far that type of use of technology that's the most evidence-based for at the moment. We call it internet-based digital mental health interventions, or more specifically, because this is what's been used most, cognitive behavioral therapy. So I don't know your backgrounds, but do you know what cognitive behavioral therapy is?
It's very diverse.
Right. Well, anyway, for those of you who are not sure, this is a certain type of psychotherapy where you intervene on thoughts and behavior primarily, and that affects the whole system and makes it change. So hopefully then the disorder disappears, right? So, and it does for a lot of people in some disorders, but not so many in others. But it's the psychological intervention with the best evidence base. So, and it lends itself well to transfer into self-help materials. So what we started doing was creating online self-help materials for depressed patients, for example, anxious patients. So it could be something like this, like pre-recorded videos. This is our good actor, Rikke, who was in a program that I helped develop, because it turns out, actually I think this was in the Netherlands, they found out at some point that if you make a psychologist act to be a psychologist on screen, it looks like a bad actor. But if you make a good actor act like she's a psychologist, it looks like a really good psychologist. So we copied that and used an actor for ours, and she was really good at that. So this is one way of communicating psychoeducation and intervention types. And you can do stuff like, so normally in CBT you have you get an A4 piece of paper with 5 columns on it, with situation, triggers, and thoughts, behaviors, emotions, results, something like that. And but here you can have a model like that develop as you enter your data into it. So this, for example, just starts with a black dot in the middle of the screen saying click here, you click there, a help box pops up saying type some of your like think of a situation where you felt bad and type that into this box, and then click next. Okay, so you type in the situation where you felt bad, click next, and then it animates an arrow going to negative thoughts, right, to convey idea that then triggers your negative thoughts, and then that develops into emotions and bodily sensations, which then animates onto behavior, and that then ends the circle, which now becomes a vicious circle, right? Because these re-emphasize each other. So this is a way of using like the digital tools to emphasize what was intended with the original scheme. So sometimes there are opportunities to actually improve on, you can say, the materials that we use, because we are using a digital tool for it instead. So that could be an example of that. A more modern example is this. We've just developed for children and adolescents called Cool Minds, where you can see there's a lot of animation, there's very little text, and you can probably guess from the format that this is made for the mobile phone. But it's the same idea. It's a sort of self-help material. You go through the same types of interventions as you would in traditional face-to-face cognitive behavioral therapy. But the difference is that it's delivered or communicated via this platform rather than by a therapist. Yeah? But it's set up so that you have contact to a therapist. So you can do this either as completely self-guided or self-help, or you can use it with guidance. That's how we've done in the clinic. That's the one you were referring to in my introduction there, where we developed a national centralized clinic for ICBT. And and this was really pioneering work. There was no house in the beginning. I was sitting in sort of a governmental building and designing this, and then I employed a couple of therapists, and then we started in a newly small built barrack, literally on a parking lot in Odense, city in Denmark, and we came with, you know, a coffee maker under one arm and some toilet paper, and then we just, okay, so we built a clinic now. And anyway, so that ended up being this this national ICBT clinic, and this is built around the idea that we have then a team of psychologists supporting people to go through this intervention, but the intervention itself or the materials itself are really, you know, on the platform, on the digital platform. So that means that one psychologist can now manage many more patients at any one time than that person would be able to if it was all face-to-face. So it's a more low-intensity treatment, but it's low threshold and greatly increases the amount of patients one psychologist can manage. But you can also do it as a blended care format where you also include actual face-to-face consultations, like traditional consultations, but then in a lower number than you would normally do. So instead of having the full face-to-face therapy, you would maybe only have half as many consultations, and then the rest of the interventions, so to speak, or sessions in a way, would then be online self-help materials that would fit in between the consultations. And finally, So the big question, of course, is if this is really possible. So pushing a machine self-help material into such a sensitive personal relation, does that actually cause the same or cause change the way that we want to? And the surprising question is that it does. You can see in the meta-analysis made by an Australian psychiatrist back in 2010, we listed all, RCTs, and as long as it's you can see the dot is on the right side again of the middle vertical line here, it's an effective RCT, and you can see they're almost all very effective. So that emboldened Swedish team to see, okay, what if we do the same meta-analysis, but where the comparison group is face-to-face CBT, and then they came out with zero effect. So there's no difference. So that's now it really starts to worry us clinical psychologists. Right, and this was repeated. Andrews did another, repetition of this in 2018 and found the same thing. But as you can see now, there are many more RCTs in this. And so the Swedes, of course, they repeated theirs as well, and they found the same thing. So it's a pretty steady result, and it's quite surprising, really, I think, that you can do. So this is all guided. So it's not even the blended format, but you still see almost the same effect as you would see in face-to-face treatments. So it does seem to be possible. We're not exactly sure why that is the case, but it is the case, it seems. This is a study I did on blended care, actually together with you as well, with the EU, or I was affiliated with the EU project, eCompare. But so this is just a Danish trial on 76 patients with depression. So they had moderate, some of them had severe levels of depression. And you know, the two lines here, the two different colored lines are the symptom levels progression through the therapy. And as you can see, they are almost identical. So it seems like whether it's blended or face-to-face therapy made no difference. So this was actually 12 sessions of face-to-face compared to only 6 sessions of face-to-face, but then with these online materials, as you can say, alternating between the sessions. So it's very similar, also for blended care, even with a higher level of severity. Okay, so let's change to a different type of, yeah?
Brief question, are these persistent effects?
Yes, they seem to be. There are not that many studies with long-term follow-ups, but those there are seems to be persistent. Actually, a lot of them are improving over time. But then again, a lot of them have access to the self-help materials after they finish treatment, which is, I hope, well, because it's a very easy sort of way to prevent relapse and and worsening of effects.
So it was also on large cohorts, like hundreds of people, taking each of their...
Yes, so the eCompare study, for example, we've made that was 10 different trials, 9 different trials?
I think it was 7. I think you were the 7th, 6 or 7.
Ah, that might be the case. Yeah.
It was 800 people in total, 830 something. Yeah.
And that was compared to tau, you know, treatment as usual.
Yeah.
And don't tell anyone because it's not published yet, but it does look like it's the same effect, maybe even a little bit, but it's certainly the same effect. And I think some of it has to do with, we don't say this out loud often, but treatment as usual is not always very consistent and very evidence-based. But this will always be, because you have to structure your treatment around an existing system that is built on evidence-based treatment. Mm-hmm. So it kind of lends itself natural to an evidence-based therapy. And that increases probably the effect as part of it. Yeah.
But okay, so treatment with the normal psychologist, I understand, and the online module, is it fully self-driven? So the patient is on his own?
Yes.
There is no instructor, no master?
Yeah, there's guidance, right?
So, but
or just these snippets of video?
Yeah, so in blended care, you'll have this online program, which is videos, for example, interactive exercises, some psychoeducation, some written things, or, you know, case earlier, the people who talks about how they themselves came over a depression following a depressive program, for example, or something like that. So there's a bunch of different materials in the online materials. But then, say, in blended care, you alternate between having a session with your psychologist, then you go home, and then you maybe have 2 weeks where all you do is work with this online material, no help at all. Then you come back for a consultation. So that will be alternating between online and offline, you could say. And even the online sessions can be video-based. So then you can reach like all of the Netherlands, for example, from the same centralized clinic. But you can
help yourself works.
Yes.
As long as the patient is like determined to actually help himself.
Yes.
Are the severely depressed people also taken into this trial?
Normally they're not.
Will they follow this?
Normally they're not.
No.
Normally the limit is between moderate and severe.
Okay.
It does look like severity is not a very good predictor. It does look like complexity might be. So comorbidities or social complexities or other things around the person, but not necessarily severity. In fact, it often seems like the more severe you are, the bigger the change, which could of course be regression to the mean, but it also looks like there's a bit more effect there. except there might be a threshold, but I don't think the literature really agrees on where that lies yet. But I think I saw it a little bit in my data set, but it was too few patients to generalize from. Almost, it does seem like it works up to, like, more severe than I at least would intuitively think would be correct.
Yeah.
So, okay, let's skip to video consultations. That's another digital tool. I think this has become, of course,
Someone joined who has the microphone on.
Yeah, please switch your microphone.
Please switch
your
it
microphones off. Okay, so video consultations, everybody knows after the COVID, yeah. So if you look at the usage statistics, this went all over Europe. This went up enormously under COVID, and then after COVID, it fell down again. So everybody are willing to use video consultations if it seems meaningful and necessary, apparently, right? And if you look at there is some evidence of that. It seems to have same clinical effect. So if you do therapy over video, it will have approximately the same effect as if you did it face-to-face. No real difference. And also that goes for assessment precision, which is perhaps even more surprising in some ways. All of these numbers, I think you should probably think of them, taking them with a little bit grain of salt, because it's, as you know, all studies, or experimental studies, are only made on persons who were willing to participate, which means that it's those who are already sort of see the light in this, yeah? So it probably exaggerates the effect a little bit compared to if it was just implemented in a health service somewhere, but still it's pretty impressive, I think. Virtual reality. So that also seems to be able to work for exposure therapy for anxious patients, for example. I think one of the really cool uses for this is in social phobia, where some patients you can't have them start their exposure therapy before they are a little more comfortable, but they'll never get more comfortable because they don't get out, so they don't expose themselves. So, you know, their cognitive patterns never change, and this sort of vicious circles locks them in the disorder. But if you can then start with virtual reality, where you can control the triggers, the anxiety triggers, so you can start with something that's very easy for them and then step it up, then you will see that effect persists into real life, and they can then start in vivo exposure out on the street, in the shops, and whatever they are afraid of. So this has also been used for other things. One of the more interesting new studies I've seen going on with this is for people who hear voices. So they've invented a system where you can recreate in virtual reality a face of the voice that you're hearing. So you describe it, and then someone will sort of create that, and then how the voice sounds. And then the psychologist will then be in the room with a microphone, saying some of the things that voice normally says to the patient. And that is then being modulated, so it sounds like it does in hallucinations. So you get this externalized hallucination, essentially, but one you can experiment with. So now you have an example of sort of psychological decentralization. You can step back from the actual stimulus, and you can experiment with it and manipulate it. So so the patient get a sense of agency and control, and they can work with that. This is still ongoing, so we don't know if it works yet, but the preliminary results are quite impressive. I've heard a patient talk about this who tried it, and she got completely rid of her auditory hallucinations. I think that's a very interesting way of using technology. Next level, and on very severe level patients. And there are actually a lot of people who have some level of auditory hallucinations without them being schizophrenic per se, but this is a pretty common problem. All right. So I can never tell if it's waiting to change slides or if I didn't hit it yet. Oh, here we go. So this is an example of a study going on at the University Hospital in southern Denmark, exposure for triggers of social phobia, as I was talking about before. They just finished it and it's writing up the results right now. I think they look promising, but let's see when it's all done. This was the challenge project. That's the one I was talking about with the avatars externalizing. This is from Copenhagen, Denmark. So I'm sorry if it's a little Denmark-centric, but it's just to take examples of something I know of. All right. So I'll just skip to tools for monitoring patients' conditions. So it's a bit of a tour de force through a lot of tools, but to give you an overview of what's going on. So monitoring can be something like this. The ubiquitous mobile phone can be used for that. We use that in the Reconnected study. We use that in a lot of studies. You use that for monitoring all sorts of things, but you can also use it for monitoring depression, for example, in different ways. And then you can feed back the result to the patient, and you can also feed it into, this is from a commercial system called Monsenso, and you can feed that back into the clinician's web portal, so they can see, get an overview even of enormous amounts of data, and then they can use that together with the patients, so it becomes a more data-driven approach that they use together. This is a finished product. A lot of you probably know this, the Aura, I think it's called, ring. So this monitors blood flow through the finger, which from that you can monitor pulse. It can also monitor a few other things, and then through clever computing of that data, it can give you outputs on, say, sleep or activity or other things like that, even early signs of arrhythmia, cardiac arrhythmia. So there are simple, very non-invasive monitoring devices now that you can wear all the time. Example of a wearable. This is a bit more exotic. This is something that is to come. This is from Aarhus University, engineering department, of course. They figured out a way to have in-ear EEG, so you can monitor brain waves from sensors in your ears. Now, why would you do that? So one of the really cool advancements of this, in my opinion, is that from this you can monitor not only sleep or wakefulness, but you can monitor sleep architecture. So we have 4 different sleep stages of sleep, and you can see the changes between that, or 5, depending on how you calculate. And you can see that from this because you actually monitor the brain waves. So that's that will then give you an impression of someone who sleeps enough but is still tired, what's happening during sleep. And it's easy to wear.
You can also play music, like AirPod.
They can't. These can't. No, just monitoring.
Because then it will become very popular.
But you can maybe, with time, include these in your AirPods.
Yeah.
I don't know.
Remove the wires, of course. You don't want to sleep with wires around your neck.
No, true. Yeah, so it would be nice if it was wireless. So this is something, when I first saw this, I thought this is pretty cool and futuristic, but I've just seen that this is an actual commercial product now. So what it is essentially it's a Wi-Fi router, right? So you have a small wave emitter or radio wave emitter, and then you have a receiver, so you can see those radio waves come back at you. So what you can measure then is the Doppler effect of things in the room. Yeah, you know the Doppler effect? From so an ambulance going by going, it changes sound because waves are compressed when the source is coming towards you, and then they're stretched out when they're going away from you, which means that you will hear the change in frequency. So this you can measure on radio waves as well, even though it's extremely quick because it's electromagnetic waves. But they can measure it so finely that they can monitor where the patient, say in a hospital bed, is breathing. So that's one thing. So you can monitor whether they're breathing or whether they are active or something like that during the night without waking them up, which is actually what's happening today. So literally the nurses go around in the rooms and open the door, and then that wake patients up. So patients with sleep disorders, for example, are being this is for security purposes. You have to do it with patients with serious mental disorders in hospitals. So stuff like that is also coming out now for monitoring. Right. So I'll just take a quick measure of time. Actually, I'm sorry, I am skipping this.
Oh, we already announced this.
Yes.
It's the most
We're
difficult
skipping
part.
implementation, but then we are lost.
Yeah, so you can never get it out in the world.
Then we have to ask you to come back.
Yeah, that's what I thought about all along.
That was the plan.
Well, I wanted to see if I could find my slides on the reconnected projects.
Oh, nice.
Yeah. So, this takes forever. This one. Okay, so the Reconnected project is of course the most fantastic project. And no, so this is an example of how we are also now trying to use these sorts of ideas for prevention. So it turns out, more or less, this is Pim Kuipers, for example, from the field where you're from your department, who has done a lot of meta-analysis, who says that it does look like the effectiveness of therapies, pharmacological or psychological therapies on mental disorders pretty much haven't changed since the 50s. So that's pretty sad. It's a little better. It's not too bad, but it's a kind of the same effect size, and the effect sizes across pharmacotherapy and psychotherapy are about the same for the same disorders. So really, he says you need to start focusing on reach, of course, but also on prevention. Yeah. So it's better that people don't get sick first. So this is a way of using complex systems, which you work with a lot. That's why Claudia, your team is also included in this, and then working with essentially just-in-time interventions for vulnerable groups across Europe. So just a few stats on the project. It's 54 months. It started last year. 5.5 million euros, but it's 11 partners.
Already complaining.
Yeah, I think this is interesting because you see pretty broad spectrum of countries when we include Kosovo there. So we have low-income countries and or low to middle-income countries, and we have the high-income countries, and we have different groups across Europe. So we are trying to then use this integrative conceptual framework. So Claudia, this is your fault that it's this complicated. So it's not just psychotherapy anymore. Now it's become really theoretical and complicated. So what this is that we've tried in the project to make a conceptual framework about what is connected to make somebody vulnerable, to say it simple. So there are contextual factors, there are internal factors, social factors. So how does these connect overall? And then we're just starting up a cross-sectional study across Europe in different vulnerable groups to see if how this is expressed in these groups, right? So we'll see if the framework holds essentially, but we'll also improve on the framework and then find actionable points, target points for our interventions later on, or prevention interventions. So it's youth for Finland, it's elderly with loneliness here in the Netherlands, it's South American immigrants into Spain, it's youth in secondary education in Germany, and youth in Denmark from 16 to 20 years of age, and adults in low socioeconomic status populations in France and in Kosovo, and elderly with loneliness also in Switzerland, and non-Western migrants in the UK. So it's very different populations, you can say, which also we can see now, because particularly the Spanish team is building the interventions that we're going to use. And there are now 42 modules included of different types of interventions that can be delivered to different people. So now we need to figure out when each person needs one, which will also be using artificial intelligence to help us guide that sort of individualization or personalization process. So we call it a digital support system that we're building. You could also call it an app, but it's built on 3 legs. So one is health literacy, what are people's understanding of mental disorders and how to receive help. Broadly speaking, it's a lot of interventions built on psychological interventions, but also other elements. And it's, what's the final leg? Final leg, there are 3 legs.
The social prescribing.
Social prescribing. Is that even on here?
Yeah, it's on there, yeah.
Oh, okay. So social prescribing is something they experimented with, I think, in the UK for some years, where you're kind of giving social activities on prescription in a way, or it's a way to engage people in their communities. Right. So just briefly an overview here. It seems to me when looking at this field that we started looking at, is it even feasible? Can we do interventions? This is particular with interventions. Can we do interventions where we push machinery into such a delicate relationship as a therapeutic relationship? So that's kind of the first types of questions. There are many variations of this. And then it moves on to if it's effective. Does it change anything? And does it change what we hope it changes? And does it have negative effects? Now it's moving up towards what works for whom, because we can see it doesn't work for everybody. So who is not benefiting from this, and who is benefiting from this? Can we see something in their characteristics, either at baseline or early on in treatment, from process variables? And now we're starting to, first projects are starting with to use this knowledge, which is still very young, really, but still using this knowledge for personalization, like in the Reconnected project. I also have a different project running where with the breast people, where we're trying to personalize certain interventions to certain psychopathological profiles. So this is kind of the travel it's been taken, and as parallel to this, the question of how do the things that we already seems to know work, how do we start implementing that into routine care, which turns out to be really difficult. The uptake there is low. So what's the barriers, or what are the facilitators for that types of processes? That runs in parallel with soul development arrow, I think. All right, so I think that's it for now. We still have some time for questions.
Now, first of all, and with this last slide, it's also it's actually really a bit of it brings a bit of a positive mood while it's dark outside. And, so there is really a lot of progress. And like, when did it really start? The e-health.
Good question.
Was the first start? What was it? Maybe the 90s or something.
Well, actually,
80s.
I would probably point all the way back to the 60s, because you had the very first experiment that I know of with this was the ELISA program from Weizenbaum. I think probably some of you have heard of that. It was a computer scientist who worked with. So he built a small program where you could directly chat with it. So it was kind of like we think of chatbots today almost.
Yeah.
And gave it a name, and you can talk to this fake therapist, and then he built it on Rogerian psychotherapy, which is pretty much mirroring, to make the patient reflect on his position or her position. Yeah. It was a very simple program, and it couldn't really do much. There are examples of it. You can find emulations of it on the internet today. Yeah. But he got really scared with this, because it turns out his secretary got really into a discussion with this program and got so close with it that one day she asked him to leave the office so that she could talk with Eliza. and he thought, okay, I've developed the devil. We need to get off this path. And he spent the rest of his career advocating against it, actually. So that's one of the first examples of this. But then you have this internet-based therapy that I'm talking about.
I'm going to stop you here because I only wanted to say that in a relatively short time frame, we have an alternative, an evidence-based alternative using some kind of technology.
Yes.
That actually seems to be, if there's some kind of guidance, it seems to be as effective as the face-to-face interventions that actually are there also, I think, since that are evidence-based, like since the 60s, 70s.
Sure.
And I think that at the moment when the large trials became to be conducted and published and so, that sort of was in the 80s, 90s and so, so
yes, 90s.
So it's a relatively short time
actually,
frame, and now most of us think it's normal that automatized interventions with some kind of guidance are effective. So that's a progress in a very short time frame.
Yeah.
That's so when I listen to your story, but anyhow, I want to open up the floor for questions and discussions.
Yeah, please.
So if you're online present, maybe just type it in and we get back to you. So we start here. Yeah.
I have a question.
Yeah,
so
Nina.
Going all the way back to the beginning of your story, that half of people with mental disorders aren't treated.
Yeah.
Is the main reason for that just the large demand, or are there more reasons? And what thresholds does this take away?
Yeah, really good questions. Plural, I guess. But so there are different barriers for seeking treatment for people. Some of them, the most common ones, are stigma. Still, you might not think so, but it's still a big problem. Particularly if you have to go to a mental hospital, people generally don't like that. And then it's expense. It's still something most people need to pay for themselves out of pocket, or parts of it out of pocket, which is still expensive. Then it's really, as I mentioned, even presence of proper level of care. So do you have psychiatrists or psychologists, for example, in the town you live? And it's that's pretty much the answers to the second part of the question as well, because it lowers all of those barriers. Most people consider this sort of anonymous. It's not at all, but it feels
more private.
It feels more private, and it's much cheaper. So the clinic that I built, for example, is funded 100% by public funding, which means it's free at the end point of the user. And what was the last one I mentioned? Oh yeah, that was free, and then it's accessible. So in the Netherlands, I think it's 98% of all people have access to the internet, and has a mobile phone or a computer. So it's accessible everywhere, really. And so it's the same sort of barriers it lowers. So it feels like a lower threshold.
Nice. Yeah. I have one other question.
I'm going to stop you because there's someone here as well. We might get back to you. Barbara Schouten has a question. Maybe, Barbara, you can actually do it yourself. I see you're sitting there. Hopefully we can hear her.
I can do this and I can see her as well?
Yeah, you can see her. This is Barbara.
Yeah. Oh, okay. Hi, Barbara.
Excellent.
Hi, Kim. Can you hear me?
Yes, clearly.
Great. Well, thank you for your nice presentation, and I'm really happy to see this reconnected project. It's great. At the same time, I was wondering, if you talk about effectiveness, you talk about the therapy effectiveness, but I was thinking about effectiveness in terms of increasing access to care. Is there any evidence? That's the first part of the question. Is there any evidence that you know of that there's a correlation between regions or cities or whatever in which there are more technological possibilities and lower or higher access rates? And if so, if that is the case, is there any role of cultural adaptation of intervention elements in that that enhances this access in this case?
Okay, so let me just make sure that I understand you correctly. So are you asking if we then for example, in Denmark, where we created this program for all of the country, is it then sort of adapted culturally to all
that's the second
people, all cultures in the country?
Yeah, that's the second part. You started your presentation with saying there's about half of the people that need it don't get access to mental health care services. And then technology is propagated as one of the ways to increase this access. So my question is there any evidence for that? We know that
it actually does increase access.
It does?
Well,
what way and for whom exactly? Can you elaborate on that? Because
yes, I can. Let's start there. So I can't do that, but I think the easiest for me to say with that is the clinic that I've been involved with in Denmark. Yeah. So so there are 2,000 patients coming through that every year now, and if we look at the dispersion across the country, so where do they come from? We see that they come from everywhere across the country. Yeah. And we see that it has the same spread in between females and males, and it has the same age spread, the same severity spread, and that. So it's just 2,000 patients who otherwise wouldn't have gotten any treatment. So I think that's a pretty solid evidence that this reaches out to many people, and actually the government just put it on the on the national budget, and they wanted to increase it to double the capacity. So that's a pretty big increase in capacity. Okay. So that's definitely the case. For the second part of your question of cultural adaptation, I think that is lagging behind, because we saw the first program that I made in a hospital that was translated from English. It was a UK-based program. We translated that to Danish, and then we found out that translation just wouldn't work in Denmark. It's really, so even if it's like countries that are relatively similar, globally relative to the globe, it is still different way of speaking, different relational style between a therapist and a client, and so we needed to adapt that to Danish culture. Yeah. But then also there's an element of, now that you make a reach to everybody, is it present in Arab, for example, or languages, or is it can it work in other cultural? Obviously the same even for men and women. What about children? Is it so there are all this diversity that it needs to address, and I think that's something that's coming now, that it's being within country translated and adapted to different cultures or target groups.
Yeah. Thanks.
Okay, thank you, Barbara. Great. If you stop sharing, you can also
all right,
see. Yes. So there is room for another question. I'm just looking also at people who didn't address anything yet. Maybe you, Eugene, you're from Rwanda. You want to test the digital intervention, right? Or you, Shakuntala? Huh?
I do have a question.
She? Yeah, we just want to stimulate as well the PhD students.
Yeah. I was just wondering, because there's a lot of news about people getting very attached to certain artificial intelligences and this kind of going wrong.
Yes.
I was wondering how you're dealing with that and what kind of boundaries or thresholds you're setting to prevent this.
That's a very good question.
Can you repeat the question? Because
yes,
I think
so I'll just repeat the question. So the question was that is seen in the news now that chatbots based on AI generates like very strong connections to the patients or to those using it, but sometimes the AI will do like completely hallucinate or say dangerous things, and how do we address that, really? That's the question, yeah? And that's totally correct, and it's still not solved, so not at all, like by far. So it's I would say that that's a very immature technology. I would say it's dangerous at this point. We've just seen a law, what's that called, a case, legal case in the US, a family whose son killed himself, and the family is convinced that had to do with his interaction with an AI. So and which I think seems, you never know if the causality is that simple, but there's some evidence to support that, really. So, so this is very dangerous, so I think there's a lot of things that I would like to say about that. So let me start with that. With can you train an AI to be not dangerous for a patient? And I think the answer is that we don't know yet. So but it is going on in research. So I have, not my PhD student, but a PhD student in my department is actually working on an open source AI model and then seeing if he can include restrictions or train it on a specialized data set, or do something with the interaction styles, or so trying out different elements in that, or limitations to its freedom that will make it safe. Yeah, but it's still ongoing, and so far I don't think so. It might come, but it boils down to a question of the wording artificial intelligence, which I really don't like, because it implies that it's an intelligent entity, which it's not. Really what it is a neural network, which is very good at categorization. Right? You know more about that than I do, I'm sure, but so correct me if I'm wrong, but I think really what it's doing is just predict the next word with highest possibility. That's pretty much what it boils down to. So all it does really is it read through the internet, more or less, or in a large part of it, and then it just guesses the next possible word. Yeah, and that's got nothing to do with intelligence, really. Not as we perceive it as human beings.
Not yet.
But so I think really this is it's an example of machine learning, I would say, probably. Yeah. So and machine learning can be used in many different ways, or maybe it's the other way around. It depends on how you use the terms. But
Kim, I have to stop you because it's the end of the time.
All right.
But please stick around if you want to discuss this a bit more. And we would really like to thank you also on behalf of everyone who joined online for this exciting talk. And we definitely should have you back because there were more questions in the audience. But yeah, unfortunately, it's end of time. People have to go.
Of course.
Thank you very much. Thanks a lot. Bye-bye.